Well, hello, my name is Jacob Abraham, and I am the section head of the Advanced Heart Failure Program with the Providence Heart Institute in Portland, Oregon. It's a pleasure and an honor to be invited to speak at today's conference, and I want to thank the conference organizers for the invitation to speak on active unloading during VA-ECMO for cardiogenic shock. The objectives of today's talk are to discuss and help the audience understand the hemodynamics of veno-arterial ECMO, to understand the differences between venting and unloading, and finally, to review clinical outcomes of ECPella, which is the combination of VA-ECMO with an Impella device. So for background, the VA-ECMO or veno-arterial ECMO is a form of temporary mechanical circulatory support in which large bore catheters are placed, in this circumstance, in the periphery to direct blood from the venous circulation through an oxygenator and then redirect the oxygenated blood into the femoral artery and direct retrograde blood into the arterial circulation. The advantages of this approach, as you've already heard, are that it allows for rapid bedside support of patients who are in extremis. It provides biventricular support in that it unloads the right side of the heart and increases systemic perfusion. It provides gas exchange, including oxygenation and carbon dioxide removal. In contrast to other forms of mechanical circulatory support, such as a balloon pump, the support from this device is not dependent on native heart rhythm. And additionally, using VA-ECMO allows for simultaneous use of the ECMO circuit to provide continuous renal replacement therapy. Now, the disadvantages, as you've already heard, include the fact that these are typically large bore cannulas, on the venous side as large as 21 French, and on the arterial side as large as 17 French. Patients who are cannulated peripherally are obviously unable to ambulate, though there is some work at some centers going into ambulating these patients, but that is not standard of care as yet. And as we'll discuss later in this talk, VA-ECMO increases afterload, which is an important facet when we consider its use in cardiogenic shock. And finally, this particular form of cannulation raises the potential for there to be regional hypoxemia, as we will discuss. But before we dive into that, I just want to provide context that the use of VA-ECMO has expanded dramatically over the past decade. Shown on the left-hand side of the screen are observations from a German registry in which you can see there was a quantum leap in the use of ECMO in 2013, 1 year after publication of the negative IABP shock study, which showed that routine use of a balloon pump in cardiogenic shock did not demonstrate benefit, and that must have or may have translated into increased use of ECMO, both for cardiogenic shock due to acute coronary syndromes as well as decompensated heart failure. And on the right-hand side of the screen, you see the increase in number of use of ECMO in all comers with shock from the ELSO registry, which is an international registry. And you can see, again, marked increase in the use of ECMO over the past decade. But the other point that I want to make from this slide is that the in-hospital survival over this entire time period has remained relatively stable, with about a 40% survival in unselected cases, which highlights the need for us to best understand which cases may benefit from ECMO and to understand the hemodynamics. So to that end, I'd like to revisit some basic cardiovascular physiology to understand some of the critical issues that help us understand how ECMO may load the heart and how we can prevent some of these complications. So to begin, most of us are familiar with the changes in pressure and volume of the heart over time. And because both pressure and volume vary with time, we can remove time from this depiction and now present a pressure volume loop, which depicts on the right-hand side of the screen one cardiovascular cycle with the mechanical events from the left-hand side of the screen shown in their corresponding position in the pressure volume loop. For the purposes of this talk, there are three major parameters that I'd like to focus on from the pressure volume loop. The first is the end-systolic pressure volume relationship, or ESPVR, which is indicated at the top left of the figure. This end-systolic pressure volume relationship is an index of left ventricular contractility that is relatively independent of loading conditions on the heart. So the steeper that line, the more contractile the heart, and conversely, the less steep the line, the less contractility there is. Similarly, the end diastolic pressure volume relationship shows how when the heart fills or increases in volume during diastole, pressure in the heart increases. So this demonstrates essentially the diastolic stiffness characteristics of the heart. And then finally, the space enclosed by the two vertical portions of the loop indicate the entire stroke volume during the cardiac cycle. And there's one other parameter that I'd like to highlight, which is the effective arterial elastance, the line shown in red, and its slope is indicated by E sub A, or effective arterial elastance. This is effectively a measure of afterload on the heart and can be estimated by systolic blood pressure divided by the end diastolic volume of the heart. It's essentially the amount of pressure that the heart can generate for any given volume at end diastole. And this is an index of afterload on the heart. And one can see that as there are changes in afterload, such as an increase in total peripheral resistance, the slope of this line increases, indicating increased afterload, and conversely, as peripheral resistance decreases, the slope of the line decreases. And in an ideal setting, the end systolic pressure volume relationship and the effective arterial elastance, the ratio of those two slopes should be about 1, indicating that the heart, the function of the heart, and the elastance of the, or afterload of the heart, are well coupled and well balanced. Now, taking these concepts and integrating them in the context of cardiogenic shock will help us understand the effects of interventions. What you see here are pressure volume loops for both the left and the right ventricle in the setting of an acute cardiac event, such as a myocardial infarction. And as you can see, as the MI evolves, the stroke volume of the heart begins to shrink. The slope of the end systolic pressure volume relationship decreases, indicating decrease in contractility. And there is a rightward shift of the pressure volume loop on the end diastolic pressure volume relationship, indicating that left ventricular end diastolic pressure is increasing. So we're able to capture, using the pressure volume methodology, multiple events that are occurring during the development of cardiogenic shock. Now, using the same framework, we can now understand how ECMO impacts the physiology of cardiogenic shock. So again, here we have now a patient who's in cardiogenic shock, and we activate veno-arterial ECMO. You can see that there is again a rightward shift, a further rightward shift in the pressure volume loop. This occurs because the pressurized blood returning to the heart actually depresses the amount of blood being ejected from the heart, so pressure and volume both increase in the heart. And you can see that the stroke volume is further reduced, illustrating the fact that the VA-ECMO further increases load on the heart. And so this is why when we consider this over time, as VA-ECMO flows are increased, we're further loading the failing left ventricle. So when we think about using ECMO to support patients who are in cardiogenic shock, we see that for a failing left ventricle, this is actually not going to be promoting left ventricular recovery. And you can see this here from an actual patient, that as ECMO is activated and flows are increased, left ventricular volume decreases, or rather increases, but left atrial pressure increases. Another aspect of the physiology is that we have mixing of blood being ejected from the native circulation where it meets the retrograde blood flow from the ECMO circuit. And this creates the potential for there to be upper extremity hypoxemia while the periphery is well perfused. And there's a balance between this mixing cloud as a function of ventricular contractility as well as ECMO circuit flow. And the consequences of this loading are significant, and in the most extreme cases can include stasis in the aortic root, which can lead to aortic root thrombus, can actually lead to lack of closure, or rather lack of opening of the aortic valve, which can lead to thrombus of the left ventricle, and certainly the increase in left atrial pressure can lead to pulmonary edema. Now, to mitigate against these adverse effects of ECMO, there have been many potential ways in which the left atrial pressure can be, and the left heart can be vented, including passive strategies, including inotropes and vasodilators, as well as an intra-aortic balloon pump. More aggressive strategies or invasive strategies, including balloon atrial septostomy or direct surgical cannulation of the left atrium. And then finally, surgical venting of the left ventricle, or in contemporary era with contemporary devices, the use of percutaneous left ventricular vents. And I won't summarize the many advantages and disadvantages that are shown on the slide, but you can see that some of these more aggressive approaches can be technically challenging, whereas unloading with the percutaneous vent allows for bedside implantation, provides direct and active unloading of the left ventricle, which can be controlled simply by adjustment of speeds of the transvalvular pump. So let's see, using our pressure volume analysis, how concomitant use of a transvalvular device such as the Impella would work in combination with an ECMO device. So here again, we have our pressure volume analysis. We have a patient who's in cardiogenic shock. ECMO is again activated. We again see the rightward shift in the pressure volume loop, the diminution in the stroke volume. And now we activate an Impella CP device. And as you can see now, there is a leftward shift in the pressure volume relationship, and the previously rectangular shape is now replaced by a triangular pressure volume loop because there is continuous suction and aspiration of blood from the left ventricle into the aorta. You may also notice that there's a decrease in left atrial pressure as the Impella device is activated. Now, one of the other advantages of this approach is that providing continuous left ventricular unloading, as opposed to just passive venting, is that it decreases left ventricular work. The area enclosed by the pressure volume loop, shown in panel A, gives an estimation of the total work that is being done by the heart, both as active stroke work, shown in the blue, as well as passive elastic energy, shown in the pink. And the amount of work that's done by the heart is primarily related to mechanical work. So as the heart is actively unloaded by the Impella device, the amount of work done by the device, or rather the amount of work done by the native heart, diminishes significantly. And this may be important for enhancing recovery, particularly in the setting where myocardial injury and myocardial ischemia are important pathophysiologic mechanisms of myocardial injury. So how does this play out in actual clinical trials and clinical observation? This is an observational study from a European registry that involved about 18 centers, where they compared the use of VA-ECMO without the use of an Impella against patients who have been matched, who were treated with the combination of ECMO plus an Impella device, so-called ECMELA in their terminology. And as you can see, looking at the probability of death, it was actually lower in the ECMELA group, but it came at the cost of increased bleeding and increased hemolysis. But this at least suggests the potential for improved overall outcomes when Impella is combined with VA-ECMO, and suggests benefit. This same group just published in last month's JACC Heart Failure about a question related to the timing of unloading with VA-ECMO. And they showed that the earlier the left ventricle is unloaded is associated with improved outcomes, not only in terms of the hazard ratio of death, but also with earlier extubation in patients who are treated with the combination of ECMO and Impella. And then finally, this is an analysis of the ELSA registry, which compared the use of balloon pump as an unloading device or as a venting device compared to Impella. And as you can see, again, this is an association with less in-hospital mortality, less on-support mortality using a peripheral VAD or Impella device, but it came potentially at a risk of increased bleeding and increased hemolysis. I can say that our center uses these devices extensively, and this shows our algorithm, which largely has supplanted the use of the CP device in favor of the 5.5 device. And we will oftentimes place patients on VA-ECMO and within a few hours take them to the OR for placement of a 5.5 device from an axillary position, and then use that to shorten the duration of VA-ECMO support and transition either to isolated left ventricular support with the 5.5 versus switching them to a BiVAD support configuration. So when we consider the optimal support platform for patients and we think about the objectives of our therapies, we're trying to provide not only circulatory support, but ventricular support, coronary perfusion, as well as end organ unloading. We can see that ECMO serves its purpose in terms of increasing mean arterial pressure and unloading the right atrium, which allows for improvement in renal and hepatic function, but it actually increases ventricular loading and has a neutral effect probably overall on coronary perfusion, whereas the combination of ECMO with an Impella has favorable effects on all aspects of support. So in conclusion, ECMO in combination with Impella has multiple favorable effects, including left ventricular unloading, an association with improved mortality, and has the potential to provide less time on ECMO and use lower ECMO flows, which may have improvement in terms of hemolysis and other hemocompatibility related events. The cons include the additional access site, which may result in increased bleeding and of course cost. I thank you for your time and attention and would be happy to take any questions. Thank you.